Behind me you can see a picture of a normal skin composite. So that's skin grown in vitro. Normal skin is like a brick wall with the skin cells like the bricks, and then round them is lipid that encases the skin cells, and that's analogous to the mortar in a brick wall. And that keeps water inside the skin cells so they swell up. That means there's no gaps in between the skin cells, so that prevents allergens penetrating through so they can't make contact with the immune system.
Now when we have eczema, essentially the lipid lamella layer, that's the cement around the bricks, begins to crumble.
Okay.
And so the skin cells themselves can't retain so much of the water content, and it begins to evaporate and lose water from the skin.
In atopic eczema, this all goes wrong. The skin barrier gets thinner. We have breakdown of the lipid lamellae, so the water leaks out from the skin cells and they start to shrink. And so allergens can penetrate through easily and make contact with the immune system and then trigger an inflammatory response. On different parts of the body, the skin barrier has different thicknesses. And what's fascinating is the skin barrier is thinnest in someone without eczema on the face, eyelids, the flexures. And these are the sites that are predisposed to eczema. So the thin skin barrier is thinner on the face and the flexures. And then in atopic eczema, the genetic environmental interaction makes the skin barrier even thinner. So everything is about the skin barrier getting thinner and thinner and thinner, and then being vulnerable to allergen penetration to then interact with the immune system. We can measure how defective a skin barrier is by looking at the loss of water through the surface of the skin barrier. And this is called transepidermal water loss. In a normal individual, they will have a low transepidermal water loss. If we then look at a set site on the body, and the classic site to use is the forearm, and compare a volunteer without a history of eczema to one with a history of eczema, we'll see the transepidermal water loss is higher in the individual with a history of eczema. If they have active eczema, the transepidermal water loss is even higher. We can repair their skin barrier by using emollients. Emollients, at their simplest, are oils with water. And the oils can be thought of as artificial mortar. So in the broken skin barrier, the broken brick wall where the mortar's crumbling, we want to put back new mortar, and we do that with the oils in emollients. And then that traps water, which goes back into the bricks, makes them swell up, closing the gaps between the bricks so allergens cannot penetrate through.
So when you actually apply moisturiser, you should rub it on in a downward direction, smooth it on nice and gently. The reason we apply it in a downward direction is in line with the hair growth. We would obviously prefer the patient to receive sufficient quantity of emollients to be able to control their dry skin condition. For a full body with eczema, it needs to be about 500 to 600 grams of an emollient per week. If they aren't receiving enough emollient on prescription, it really sends home the wrong message to the patient, and their skin will continually be subject to flares.
We have different types of emollients. So we have emollient creams that we put on the skin and leave them on. We also have emollient bath oils and emollient shower products. And the best way is to use a combination of all of these. And we call this complete emollient therapy. We've got rid of all the harsh soaps and detergents.
It's relatively simple to get the basic care for atopic dermatitis right in primary care. It's quite easy to say, but it actually takes a lot of work to do this. And the most important thing is emollients. Emollients is very, very important, and the patients have to apply it every day.
Patients can get exacerbations of their atopic eczema despite using complete emollient therapy. One of the factors is a bacterium called Staphylococcus aureus. And this is a very powerful trigger to atopic eczema. It releases proteases and lipases. So it actually directly breaks down the skin barrier from outside. The same substances can penetrate through and activate the immune system, so-called superantigens. So it's breaking down the barrier, penetrating through, and then activating the immune system.
Staph aureus is very important in eczema, in mechanism of eczema. What happens that patients with eczema have slightly abnormal skin. Although you cannot see it with naked eye, the barrier of skin is different from the barrier of patients who do not have eczema. It's not as thick, and it's easier for microbial agents to get through. And what happens is that Staph aureus have superantigen, and once it gets through the top layer of the skin, it causes inflammation of the skin, which production of chemokines and cytokines, and that makes skin very dry, very inflamed. This is very important to remember, that this inflammation creates itch and dryness of the skin, and this affects the life and quality of life of patient.
We're now realizing there's a critical level of Staph aureus on the skin above which they start to cause severe damage to the skin barrier and activate the immune system. So that we know we must keep the Staph aureus below this critical level. So that is what's meant by bioburden reduction. We are keeping the Staph aureus below the critical level above which they'll cause severe damage to the skin barrier, activate the immune system and cause a flare of atopic eczema.
What happens when Staph aureus got to a certain amount on the skin, it becomes virulent. Where it didn't cause problem before, it becomes infection. Therefore, it's very important to do something we call bioreduction. It's reduction in the number of Staph aureus below a certain level when it doesn't tend to cause the problem.
Treatment is all about a stepped approach. It's rather like the steps up a pyramid. Everyone in atopic eczema at the bottom of the pyramid needs complete emollient therapy. It is the foundation of the pyramid. The next step up the pyramid, and still involving virtually everyone with atopic eczema, is reducing the amount of Staph aureus on the skin.
We often will perform a skin swab to identify if the Staph aureus is present in the skin, and almost 100% of the time it is. So we do use the use of antimicrobial therapies to control the levels of Staph aureus.
One way to do this is using antiseptic products, such as those containing chlorhexidine. So one way we use them is 5 days we use an antiseptic wash product, washed off the skin each day, and the next 5 days we use an emollient bath oil without an antiseptic.
If we think about now how to address these issues, it's very important to use antimicrobial emollients. And what I personally recommend is to use it every day. Some doctors advocate to use it maybe 5 or 4 times a week. In my experience, it's probably easier just to keep going once a day. Just keep the level of Staph aureus below a certain level when it doesn't cause problem.
Patients with atopic eczema scratch because they itch. The more they scratch, the more it releases chemicals in the skin that cause inflammation, which makes the itching worse, so they scratch worse. In addition, it allows the Staph aureus to penetrate through the skin, triggering more inflammation, more infection, more itching, a vicious cycle, the itch-scratch cycle. To break the itch-scratch cycle is going back to the pyramid. It's going back to the foundation complete emollient therapy, the next step up the pyramid, antiseptic emollient products. We're reducing the burden of Staph aureus on the skin, so we're reducing their stimulation of the immune system and their damage to the skin barrier. So this combination of the first 2 steps of the pyramid is a very good way to try and prevent the development of the itch-scratch cycle. The best way to treat the itch-scratch cycle is through prevention.
When you think about how to treat patients with eczema, especially in primary care, probably everybody should have complete emollient therapy. But in addition to this, it makes sense to add topical antimicrobials such as Eczmol.
And rub it in a downward direction as you would your moisturiser.
And if we use the first step, the complete emollient therapy, and the second step with the antiseptic emollient products very well, we decrease the chance of the eczema flaring up and needing to go to the 3rd and 4th step, which is treating the flares with topical corticosteroids or topical calcineurin inhibitors. So the more work we put in to step 1, complete emollient therapy, and step 2, anti-staphylococcal approaches, the less chance of the atopic eczema flaring up.
Here at Leeds Skin we got involved in some of the early work on Eczmol. The initial phases of the work that we did was to prove that it had antimicrobial activity against a range of different Staphylococcus aureus. In comparison to other antimicrobial emollients, Eczmol was substantially more active. This would lead you to believe that you can either use it in a lower dose and have the same effect, or it's more effective at the same dose. Patch testing and longer term use of Eczmol demonstrated that it was just as well tolerated as other antimicrobial emollients. One of the other things that we decided to look at was whether it could be used as a soap substitute. And there's a series of standards that hand wash products have to pass. Eczmol passed these tests to the international standard. The MIC90 method is a way of doing a minimum inhibitory concentration test. When we used the MIC90 test to look at Eczmol, we found that it was 3 to 4 times more active against Staph aureus than the leading antimicrobial emollient. One of the most important aspects of using medicated emollients is to see whether they have any enduring activity on the skin after they've been applied, because this obviously leaves a layer of antimicrobial on the skin which can help to reduce bioburden over a period of time. When we applied Eczmol as a leave-on lotion, the concentration on the skin remained above the MIC level for more than 4 hours. When we used it as a wash-off product, it was still well above the MIC level on the skin after being washed off 2 hours later. So when we take the results of all these studies together, we can show that Eczmol firstly has very good activity, antimicrobial activity, that's better than the other leading antimicrobial emollient. We can also show that that activity remains on the skin after application for a long period of time, even when you wash it off. This will help to reduce bioburden over a long period of time.
When you think about treatment of eczema, it's a multi-step process. So you have to think about complete emollient treatment, but also think about antimicrobial treatments and topical steroid treatments as required. You really have to have a holistic approach to treat patients with atopic eczema. It's very important to prescribe adequate amounts of topical preparations, otherwise patients run out of the product and they don't have adequate control of eczema.